All right. Since we're done with roll call, officially welcome everyone to this quarter's Hospital Liaison Peer Call, where we will be talking about how to support NICU families. Before introducing our two fantastic speakers today, I want to remind you this call is open to both Welcome Baby Hospital Liaisons and all our staff from the Home Visiting Programs, HFA and PAT, as this is a pertinent topic for them as well. If you are just on the call, please remember that this is also a webinar. Please be sure to go to the agenda and the email that was sent earlier last week to go through the go-to training registration process to get onto the webinar portion, because we do have slides that are going to accommodate this presentation. I kindly ask you that if you are going to have side conversations, if you're going to be doing work or something else, please press *6 to mute us and *6 to unmute us. Do not put us on hold. We will get your agency's music, and that will just disrupt the call for everyone. Put yourselves on mute if you don't plan on talking. The chat box is available for you to put your questions in. We'll also do little check-ins from here and there to make sure that everyone's questions are answered as well. Does anybody? Yes.
Do you have any slides up? Because I don't see anything yet.
Yes, we currently have a set of slides up. Dr. Chon has her slides up, which reads Supporting NICU Families. Is everyone able to see them?
I am not.
Are others able to see them?
Yes.
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 Diane, you may need to log off the call and maybe do it again and see if the reset will help you.
All right.
All right, thank you. With that, I would like to officially hand this presentation over to Dr. Esther Chon and Dr. Sharon Tan, who will be introducing themselves and the work they've been doing. Thank you so much to the both of you.
Thanks, Darlene. Thank you. Welcome, everybody, to the webinar. We'll introduce ourselves. My name is Esther Chon. I'm a licensed clinical psychologist and an endorsed infant mental health specialist, working at Miller Children's Hospital in Long Beach, NICU. I'll let Sharon introduce herself.
Yes, hi everybody. My name is Sharon Tan. I am also a licensed psychologist and endorsed infant mental health specialist like Esther, and have joined her as a psychologist in the NICU at Miller Children's.
Thank you, Sharon. So we both work part-time in the NICU at Miller's. And our aim is to support families. Our NICU has 96 beds open for premature and ill infants, and 36 of those beds are dedicated to our small baby unit. That is for babies between 22, 23 weeks gestation to 32 weeks gestation. So Sharon and my focus is really to bring infant parent mental health support to the bedside. And we will discuss throughout this webinar about what that means and perhaps how programs like the Welcome Baby team can sort of help us extend that into the home post-discharge.
Mm-hmm. So yes, and also just to highlight, oh, sorry, these babies that are 22, 23 weeks, to give you a sense, they're really kind of weighing in at about a pound, right, Esther? So they're really, really tiny.
Or under.
Under, yeah.
Pound or under.
Mm-hmm.
So we'll just jump right into kind of thinking together about the impact of NICU on infant. Hopefully everybody's now seeing the slides. And I believe we can type in any questions you have about this, and we'll collect them and respond to them at the end. I believe that's how we're doing this.
Yes.
So just thinking together, we know that the environment in the NICU is very unnatural compared to the placental womb. And even though science and technology is quite advanced, and actually some things are very amazing what they can do, it still doesn't compare to the mom's womb. So thinking from the infant's perspective, they're exposed to harsh medications with severe side effects. The medications, from what I understand, are medications that we use on grown adults, and we use them for preemies, and so you can kind of imagine the effects of that. There's an average of about 10 painful procedures per day for an infant in the NICU, and as you understand, the pain experience is cumulative, so the first painful experience is not experienced the same way as the 10th painful procedure, and so you can kind of imagine the mental health and emotional toll it takes on the infant, the caregivers, whether that's the mom and the dad or the grandmother, or even the nursing staff and the doctors who are having some difficulty getting a PICC line in, etc. That it tends to kind of get pretty tense very quickly at the bedside. If we think about the isolette, it's an amazing invention. It helps to regulate the body temperature because the preemie brain, especially if you're thinking 22, 23, 24 weeks, the brain stem is not at the place where it can automatically regulate temperature for the infant. So the isolette does that for the baby. The isolette's cover on, it helps to muffle the sounds, sort of mimicking some of the sounds that a preemie infant might hear or a developing fetus might hear within the womb. We often put blankets on top of the isolette to keep the harsh lighting out. In our small baby unit, there is a requirement for the room lights to be dimmed to protect the infant's developing eyes. But even with all of these amazing sort of technological advances, the isolette is not attached to a live mom. So the baby's not exposed to the regular body rhythms of the mother, the heartbeat, her voice, her movements, all of these things, as the fetus is developing, play a very, very important role in brain development. So positioning within the NICU becomes an issue as well, because the isolette's not, of course, filled with placental fluid that allows the baby to move freely with fluidity. So all of these things have impact not only on the baby himself, herself, but also on the relationship and so forth. We are also, everything okay?
Yes.
Yeah, okay. We are also asking the baby's systems, right, body systems that are not ready to be used, we're asking it to come on board and activated way too early, the visual system, digestive system, etc. Sensory integration is a huge thing because some of the sensory systems are just being born, the visual, the hearing, the touch, and yet we're asking them to integrate already. So some of the miswirings that could happen for the baby in the NICU, we sort of have to think about that. Okay, we'll go on to the next. Sharon, jump in whenever you want to if you have a comment.
Right, absolutely.
Okay, so how does the NICU impact the parents? So we think about this, Sharon and I, as premature babies give us premature parents. We know that the babies are born premature, but we're suggesting that this also means the parents themselves are premature in their parenthood journey or parent identity development. So if you think about it, typically parents who are expecting, third trimester is a huge opportunity in their journey. So, you know, in this third trimester, the mother typically feels the baby more moving around, and they tend to engage more in sort of the parenthood journey. How am I going to be as a parent? What kind of baby am I going to have? And as the due date approaches, a lot of these sort of thoughts and narratives that the parents give and the mom shares with dad, it kind of becomes more and more rich. And then towards the end of the third trimester, the mom begins to feel more and more ready to sort of be done with the pregnancy. And we think that that prepares her for the birth and the physical separation. But if you really think about it, the premature parents haven't really gone through this phase yet. They're sort of still in the urge to protect phase. So this sort of unexpected or forced choice of the premature birth can be greatly traumatizing. I've had parents sit in my office saying that they just, for some reason, feel the urge to put the baby back in their tummy, and this is how strong this urge is. And so you can kind of imagine what's going through in their minds about some of the urges and thoughts, and am I normal kind of for thinking and feeling this way? And they are. So hence there are many grief issues. There's guilt and shame issues attached to quote unquote not being able to carry my baby to term. Some parents feel, they say they feel numb, disconnected. Surreal is another term parents often use to describe their experiences. Fathers often feel guilty for not having been quote unquote more supportive. And of course, understandably, some parents become defensive and distant. The dad will distance himself from mom and the baby. Some disconnect from both the mom's emotional experiences as well as his own. So we have, you can see some instances where fathers all of a sudden begin to work more, create more projects at home and at work. The baby's room has to get done now. We need to add another bathroom. These are some familiar things that we've heard fathers say, and sometimes mothers too. And it's understandably their way of dealing with the emotional kind of overwhelm with this, especially if this NICU admission is unexpected. So some of the trends that I've seen is that moms tend to focus on the baby as a gauge for her emotional well-being, and dads seem to focus on the emotional experiences of the mother, on how he's doing. If she's doing okay, he's doing okay. If she's not, then, what does that make me as a father? How are we going to survive this? And it tends to kind of, sort of undermine the family system, if you will. Sharon, do you have anything to add there?
Yeah, I think I just want to add that in addition to the fact that they are not ready to enter parenthood just yet, or kind of are able to wrap their minds around it, they also, especially if you have a micropremie, a baby that's really, really tiny, they really have a lot of other medical issues that come up. And parents describe kind of going on a roller coaster with the medical issues going up and down. And so they really don't have time to grow into being a parent either, because they're constantly trying to face, a medical trauma or medical issues, and really are just on pins and needles just for the life of their child. So I think there's a lot that goes premature parenthood as well, and how it kind of is also, it doesn't have as much room to progress in the NICU environment, having such heavy medical kind of concerns with their child. So I just wanted to add that.
Thank you. Okay, the next 3 slides are some of the things that parents, mostly moms, tend to say to themselves, and it's really deep and it's impactful. So worth sort of sharing and thinking about. So one of the first things, of course, is I couldn't carry my baby to term. So what does that mean about me as a mother, us as a family, and what does it mean about my baby? So in my few years I've been at the NICU, I don't think I've ever run into any mother, no matter what the situation, a mom who might have used drugs, a mom who might have not had prenatal care, a mom who didn't know she was pregnant. It doesn't matter, it doesn't seem to matter the circumstance. Every mom feels guilty and shameful for not having been able to carry her baby to term. And this is a huge influence on herself as a mother, the parent dyad, as well as their relationship with the baby. T. Barry Brazelton says often that this is the gist of all parents' questions and concerns. Sorry, I didn't advance on yours, just mine. So, but this is, am I a good parent? Is my baby okay? Is this, this is sort of what every parent's question and concern and fear boils down to. So you can imagine if this is for all parents generally, how sort of this becomes even more important in the NICU when the parents are facing the baby's health and at times with their survivability. So that's something to keep in mind.
And I was thinking on this, Esther, you know, as I was also thinking of the high-risk families that have a lot of trauma already, attachment trauma, and then possibly also birth traumas on top of being a premature parent. And I wonder about these questions. Sometimes I think that, you know, be important for you to be aware that really these questions are occurring at a maybe not a very conscious level, an unconscious level. They might not even, you know, for parents of these high risk, that fall into the high risk category, these thoughts might not be readily evident to them, but their behavior and their actions usually kind of show, you know, them feeling guilty and not wanting to come visit, not wanting to see their babies, not wanting to know how their babies are doing. It really kind of is stemming from an unconscious sense of, you know, am I a good parent or is my baby okay? It's just too traumatic to even consciously think about it and go there. And that I think would be a good place for home visitors and the Welcome Baby staff to be aware that could really be a place where it would be nice to help them bring to awareness what might be some of these questions that might be surfacing for them.
Yes, Esther and Sharon, this is Charlene. This is Charlene. We have a question in the chat box I'd like to bring up because it's relevant to this topic. The question is, the guilt about not carrying baby to term, does this vary if the reason for preterm was indicated because of a fetal or maternal medical complication versus an idiopathic preterm labor?
Yes, I read that, and I was going to respond to it because it's so pertinent to our conversation right now. And I think that when there is a clear kind of medical reason or complication, I've seen it become more conscious. I don't know that it's any more sort of deeper affecting the maternal identity or bonding, but it does bring it up front and center. And so that's the difference I've seen. Of course, you know, we have to have some evidence and some study about that. That's a very good topic to study on. The other comment I was going to make about what Sharon said, and thank you for bringing that up, that's a very good point. So I think that you see both in parents' behavior about this guilt, but you could also see it as a parent that's, you know, possibly trying to overcompensate. And so you see the parent doing everything they could possibly do, show up and visit and stay for hours on end, trying to sort of make sure that I am a good parent, my baby is okay. So I think that across the board, it's good to kind of have a good question or conversation sort of points to make sure that this is something that you discuss with parents. You know, of course, a lot of the parents who are feeling shameful to the level of shame will have a very difficult time bringing this up on their own. So a lot of good therapeutic skills in normalizing and validating, that definitely helps to address this and make sure that it's not impacting negatively on the relationship with the baby. I hope that answers that question, Jan. Thank you for that. The last sort of, you know, sort of thought that parents can and tend to have in the NICU is this, which is the negative side of, am I a good parent, right? I'm a failure, my baby's a failure. And there's no, you know, logic to how the parents get here. So we try to encourage our staff to always kind of think about things that they're about to say to the parent. through these filters that our parents tend to say to themselves, because no matter what they hear, it all seems to get filtered through these sort of subconscious narratives that parents have. So in our medical setting, we use the term failure a lot. Failed extubation, failed room air trial, failed this test, that test. The baby is not compatible with life. They hear that more on the OB end, but this treatment that we have, that your baby's not a good candidate for it. So all of these sort of messages that the medical profession has, of course, meets their need of needing to be clear medically. But if you filter it through the parent's narrative, it comes to this conclusion of, I'm a failure, my baby's a failure. So I think in the least, it's worth it to kind of think about how the parents might interpret in their kind of own way some of the words that they hear, and maybe even for support staff to sort of even think about together, how have the updates been going with the medical staff, and have you had a chance to ask all the questions you have? How have their updates been impacting you? I think those are some questions that you can use to see if there's anything there in the parent's narrative that's impacting them negatively. Yeah. There's a difference, right, in the NICU between premature babies that are here because they're early, and then the babies that are having some serious medical issues. So that population in our NICU, they're full term. Some of them may be preterm, but they have some sort of medical issue, a disorder, genetic disorder, something like that. These parents already tend to come to our NICU having experienced some of some interactions with medical team that have sort of already put them on guard. They've heard things that I think to our mental health professionals, some things are kind of unfathomable to think about, but parents hear them, things like, your baby is never going to be normal, you're being selfish, your baby's not compatible with life. These things, that sticks with you for life. It's a very heavy thing to hear, and so we want to be aware as mental health support staff, mental health professionals. If these things have been said, what's the interpretation? What's the narrative that the parents giving themselves about themselves and the baby? And what can we do to sort of undo some of the, mental health sequelae that might happen?
And I think just to add, if I may, just to add in supporting these families is, and I know Esther and I would definitely welcome it, but I think I really want to encourage, the hospital liaisons to reach out to the medical team at the NICUs if they're interacting, and to get a sense of medically how the baby is doing, to support the parents in processing whatever medical issues might be coming up. I think back to a set of parents who mom and dad really struggled to have the same view of reality of what was going on with their child. Dad wanted to deny that there was anything severe going on, and mom was more set in reality. But it really required the team to surround them, for each of them to, at their own pace, get to accepting the reality of the medical situation of their child. So really want to encourage kind of more cross-discipline discussions to support these families. So I just wanted to add that.
Thank you. The other kind of points that I wanted to also share is that moms and dads, they come into the NICU and staff have certain terminologies. They call mom's mom, they call dad's dad. And we often ask and wonder about, what would it seem like if staff asked parents, would you like to be addressed as mom or dad, or do you want me to call Mr. and Mrs. so-and-so, or your first name? Because the word mom and dad to them are loaded right now. We don't know what they're thinking and what associations they're having, but just something to check out with them. So that's one point. And then the other point is that our NICU nurses tend to refer to their patients as quote unquote my baby versus my patient. So in the least, something worth thinking about how parents feel hearing that from a person who tends to be sort of the gatekeeper, whether they're aware or not about the parents bonding with the baby, and who for right now, for some of the parents, they seem to be doing a better job than me taking care of my baby. So how does that impact them? So I just wanted to point that out as well. Okay. So what does NICU admission mean? So in our hospital, and I think in most hospitals in the U.S. for now, all moms are in one location. So meaning that a mom who gave birth to a premature baby who's in the NICU, they don't have a separate women's room area versus moms who gave birth to healthy babies. And so that means that they might have next to them a mom with her baby together. And this NICU mom who is being separated from her baby and worried about the survivability of her baby is witnessing this healthy bonding and healthy baby cry, seeing signs of celebrations. And as they leave that and come to the NICU to see their ill baby, that, you know, how is that affecting the mom and the dad? In our hospital, unfortunately, the moms get to see that, and then they pass the healthy baby nursery before they get to the NICU. So by the time they get to the NICU, they're carrying with them a lot of unfortunate negative experiences. When a mom is discharged for herself in women's and then she goes home without her baby, that's also something, a high risk for emotional and mental health issues, and we want to check that out. Seeing once she gets home and whether the baby's room was made or not, and plans that haven't been made yet. Those are all reminders of where reality is right now. And then a lot of our families approach the preset date of the baby shower, and the baby's in the NICU. That means they're going to have the baby shower without the baby there. So what is that bringing up for the parents? So, you know, what does all this mean about me as a mom, me as a dad, about my baby? And these things tend to question some of the most foundational assumptions about our parent identity, our parent being. A lot of our parents ask themselves, why did this have to happen to me, to us? What did we do wrong? So a lot of grief process that happens in the NICU. So kind of going to brain development information, we know from brain development that first experiences, first time you meet someone new, first time you taste a mango, the first date you had, all of these things create a template in our brain that become the blueprint for all future similar experiences. So we want to keep this in mind as we try to think about the first bonding experience of the parent and the baby, their first meeting. You know, we're often told that, you know, they can't connect the expectations they had, sort of the fantasies they had with reality. They're experiencing this in a surreal kind of way. They see their baby for the first time and they get surprised because, you know, babies who are born at 6 months, 7 months, it's all skin and bones. So it's not the cuddly, big-eyed, you know, kind of chubby cheeks kind of baby that we all think about when we think of baby. This is very, very different. So how does that impact, and what kind of template does that set for future meetings and bonding experiences? And then the loss of total control, even the most basic, you know, seemingly instinctive maternal, paternal urges like wanting to hold your baby when your baby's crying, wanting to feed your baby, diaper changes. All of these things are put in the hands of the medical staff. And not only that, you have to learn about how to feed your NICU baby, how to change your diaper. Even if if you're a mom of 7 other children who were born in a healthy newborn way, this baby is different. And you have to learn all over again all of these sort of basic things. And so what does that do for the template that gets set for the bonding and attachment with this baby? Sharon, you have any comments?
Yeah, no, I think also to kind of be aware of what parents bring to this first experience. I think that due to the high stress in the NICU and the trauma that they've experienced with their own attachment experiences and histories, and they're trying to kind of mesh those two together in kind of an unreal kind of situation. So just to kind of hold, internally what might be going on with mom too as she experiences this type of connection with a baby in the NICU.
Right.
Yeah.
So that sort of first experience, it's prime for setting the vulnerable baby syndrome. So parents' perception of their baby's vulnerability to this and future illnesses, that impacts the child's health, but also the relationship with the parent. And this is, of course, related to the parent's acute stress or trauma of the initial baby's illness, the initial NICU admission. So we want to be aware of this vulnerable baby syndrome. It might be helpful for the parents to hear from someone asking about their NICU experiences, asking about their pregnancy and birth, sort of giving them a chance over and over to tell their story and to kind of process, if you will, help to validate their experiences. Sometimes parents have to sort of tell their story over and over without being shut down. A lot of well-meaning interactions end with, "Oh, don't worry, your baby's healthy now," or if this is after discharge, then it's over now, don't worry about it. That tends to kind of shut down their processing journey. So it's better to kind of validate, listen, no matter how many times they have to tell it. It's their sort of need to organize and create a positive narrative. And then just helping notice, baby's health and parents' strengths as they show signs of readiness to move on. Then I think it kind of helps them to move on from the vulnerable baby syndrome. Okay. So we all know that NICU parents have a higher rate of postpartum mood and anxiety disorders. So those can be anything from acute stress disorder to postpartum depression, anxiety, PTSD. Some of the parents that stay in the NICU for a short time are told this, which is, what are you worried about? Your baby's only here for a few days. But we have to remember that trauma and stress, acute stress, etc., it's from the parent's subjective perception, not the objective nature of the event. So just to keep that in mind, because the parents that do stay in the NICU for a short time do tend to sort of fall through the cracks, and they're not given sort of the same amount of attention than parents who tend to stay longer, especially in NICUs as large as ours. Because we're a level 3 NICU, most of the parents that do go through our NICU unfortunately stay longer than a month. Some stay as long as 6 months. So they, staff tend to kind of not worry about the parents who stay there a few days or a couple weeks, but still the trauma and the stress could be just as overwhelming.
Mm-hmm. Yeah, I just want to add that I'm very glad that we have partners like Welcome Baby who do screening on a regular basis, because really on the actual NICU.
Hello, is everybody there? I lost sound.
Hello.
We can still hear you.
Okay.
I think that, so just to continue, I think the stats that I read was, I think about 14 to 27% of moms have postpartum depression, diagnosable mental health condition coming from the NICU. So it's really, really, really important and helpful as much as possible when we have contact with these moms and dads, that we run some kind of screener to make sure that we catch, any issues mental health wise early. So.
Okay, so some of the risk factors for PMAD in the NICU: if it was a difficult or high-risk pregnancy, if it was a traumatic birth, and also keep in mind that the birth is experienced by separately and individually and uniquely by whoever's there, the mom, the dad or grandma, the baby. So we have, in that case, we have 3 perceptions of the birth, and important to get all 3 perceptions. But if any one of them were sort of shared as a traumatic birth, then it could be a risk factor. Any pre-existing postpartum mood disorders in previous pregnancies, and it has not been treated, it can make the current one increase symptoms. If mom was, using drugs, abusing drugs, could it have been something that she's using as self-medication to possibly, deal with any prior mental health issues? And then the biggest thing that we've seen is that the physical separation from the infant and the loss of control over parenting, that can lead to postpartum mood disorders. So some of the needs of the premature parents in the NICU is one for accurate info and being included in the care and decision making. And this kind of sounds very obvious to us, but it's really not as easy in practice, because there's so many different health groups, discipline groups, such as medical doctors, nurses, OB team, neonatology, cardiac, GI, lactation, dietitian, OT, PT. I mean, I can go on and on. So, we have all of the specialists that any baby family would need in a hospital like our Miller Children's. The challenge that comes with that is how well we can collaborate, how well we can give a consistent care from the perception of the family. And that's really hard to do because physically we're in different places, professionally we're in different places. So this becomes something very obvious and yet very difficult to follow through on. Vigilance, right? Watching over and protecting not only the babies, but the families about where they are. If the parents are able to have contact with the infant, sometimes it's not possible medically to even touch them or even talk to them if the baby is very fragile. Even a sound that was through the covered isolette could take their heartbeat way up or down. So as much as possible, could the parents have contact with the infant? Positively perceived by NICU staff is a huge thing that encourages them to come visit often, to really participate in the caretaking and bonding process. But, groups like parents who have DCFS reports or, for whatever circumstance, they're not able to come to bedside or haven't had a chance to develop this positive relationship with the NICU staff, then it's very clear from that point on that it's very hard for them to come visit and get their needs met and bond and all of that. So that's very important. And then individualized care. So making sure if a dad is involved that we really pay attention to that dad or partner or grandmother. If it's an IVF situation, working parents, again, DCFS parents. Some parents really want to breastfeed, but medically we're now at a point where we're, supposed to sort of encourage breastfeeding, but it depends on that unique family's needs, and if they're not able, then we need to meet their need as well. So that, I think, goes without saying for us, probably preaching to the choir here. And then building a therapeutic or trusting relationship with nursing. Go ahead, Sharon.
No, I just wanted to say I think that what we could all always do to help support these parents in the NICU is to help them feel empowered to advocate for their needs and the needs of their baby. Defer to the medical team, and in just highlighting these parents' needs. Really, I think it would be nice if we could empower them to voice it. And to use, any advocacy channels that they have available to them to help them feel heard. I'm thinking of, Esther, these family meetings that any parent can call with in coordination with the hospital social worker to clarify some of these, or to express some of these needs that they have, and to get accurate information or whatever it might be. Right, Esther?
Very well said. Thank you. Okay, so some of the common NICU predictors for postpartum depression, as far as what the baby's going through, if, the lower the birth weight, right? So I think the lowest birth weight that I've witnessed here is under 500 grams. So, you can kind of tell some of the concern and fears of those parents. The longer the stay, so, that predicts overall stress of the parents. If there's some previous psychological mental health history, that tends to predict length of stay, and the substance abuse history also can predict length of stay. So those things all add on to the overall stress and increased postpartum mood disorder. Gestational age, so micropreemies and younger the gestational age. How severe the illness is, and cardiac diagnosis predicts highest level of stress. Right, so prolonged ventilation, so we have the full ventilation where they have to, the babies need to be extubated, so the tube goes down their breathing tube, their esophagus, right? And that contraption prevents the family from being able to see the baby's face, and hence there's not as much natural connection and bonding. And then from the ventilation, they can move on to the bubble CPAP, which is like a little helmet they use, and it covers the nose and the eyes, and so that also prevents the bonding. And then if there's lack of support, obviously, with the parents, that can increase postpartum mood disorders. Okay. So some of the long-term sequelae of being in the NICU. So, one of the things I ask when the parents, or if there's a, whatever significant primary caregivers are there, whether it's mom and dad, mom and grandma, whatever the situation is, one of the questions we ask is, how do you deal with conflict? Before you came to the NICU, what was your style of addressing conflict? And so depending on their style of conflict resolution, it can either lead to a negative outcome, or it can lead to a more positive, more resilient family system. So that shows you that this NICU admission is a huge stressor that really tests or strengthens the family system of conflict resolution and taking care of each other and all of that. We've talked about the vulnerable child syndrome or vulnerable baby syndrome, and that goes with the template that develops with the first experience with this baby. Anxiety in parents and anxiety in surviving children. The parents and the babies that are in the NICU get exposed to so many levels of trauma and stress in the NICU, not only emotionally, but physically. If you can think about sitting in no matter how comfortable a rocking chair is, if you're sitting in there for 8 hours straight, it adds to your stress in the body. And so you're also getting all the alarm bells and crying babies and nurse shifting going on, the shift changes. I mean, you think about sensory level, physical level, emotional level, even spiritually, it just kind of adds to such a long list of reasons for increased anxiety. And then, of course, if there's, loss, whether there's a death or loss of control, all of these add to these mental health issues. And if it's not addressed, and one of the reasons I think that Sharon and I are there in the NICU is that if we help the parents, if we meet with them regularly, if they're willing, we can kind of already start to work through and process some of these mental health, emotional kind of topics that are coming up so that they don't take so much of it or all of it at discharge at home with them. So we think that that's helpful in preventing a lot of the mental health issues. How are we doing with time? Do I have like 10, 15 minutes?
Yes, you do. You've got time. Don't worry.
Okay. All right. So some of the subcultures that surfaced at our Miller Children's Hospital last year, when we were able to do some qualitative study, were these, and we used the PHQ-9 to sort of work through who had postpartum mood and anxiety issues, and it was about a quarter. So you can kind of see for yourself what some of the disorders, some of the cultures that surfaced was. I think the huge thing for me was, some of the, I don't feel like my baby is mine. You could see that's about a quarter. That's the whole bonding issue, and how do we help the parents go from a premature parent to then grieve and learning to accept, and then finally learning to see their baby for who the baby is, and bonding and acceptance. That has been sort of the focus of our work, and from here on out, we're trying to develop a program around that, so that by the time the parents go home, they're already sort of on a pathway for positive bonding versus a vulnerable baby dyadic syndrome. Sharon, you have anything to add while
I think the other piece that I wanted to bring up too was parents with previous mental illness was also a pretty big set in the NICU where we're at, and I think oftentimes it presents as challenges in interaction with the medical team, and I think just being able to support these parents to get to the place to connect with their NICU baby is really, really important. And being able to kind of have open discussions about how to support parents with mental illness. And I'm thinking also kind of high-risk families that DCFS involved, teen parents, in being able to have successful experiences in connecting with their babies is really some of the work that I feel like Esther and I try to do as well.
Thank you. So, there we go. All of a sudden, I can't advance my slides. Oh, no. Oh, there we go. Sorry about that. Oh. There it goes. Okay, so this picture, I think, is helpful to see because this is kind of the first hold this mom is having with the twins. And, it kind of goes to a visual about just the level of anxiety and emotional overwhelm and emotional toll that families go through. And if you think about the first experiences templatizes, so what kind of template would this mom have about connecting and bonding with her twins? And for Sharon and I, who are infant mental health specialists, I think sort of the bigger goal is thinking about the brain development of these babies, right? Because we know that, yes, the brain is moldable, and there are always ways to kind of rewire. But we also have to keep in mind that the earliest brain development, such as that happens in the prenatal experience environment, so whether that happens in the womb or in the NICU, that's some of the brain wirings that are the most difficult to change. And the brain connections that happen in a prenatal environment are things that have to do with the brain structure, the physical structure. So when a child is already developed by the time they're 3 years old, 5 years old, how do we go back and restructure their brain? We can't. So this is, I think one of the reasons why Sharon and I are so passionate about what we do is that we want to provide the parents the support that they need in this moment, so that some of the brain developments for these kiddos, that it happens right from the get-go. Okay, so fathers in the NICU. These are some comments that I've had dads tell me. I feel like I'm a second citizen. I feel like I'm an accessory. They don't like to start the bonding and the caretaking of their babies because they're afraid of hurting the baby. And they're sort of, as we talked about earlier, some of the things that are, right in the forefront for dads is that I don't want to trigger mom's negative emotions. So I have to be quiet. I have to put my feelings aside for her. And they feel like that's their kind of fatherly role. So we really have to engage them and normalize things for them and make them understand that they're just as important a person and bonding figure for these babies as the moms are. Sharon, I know you have something to say here.
No. I think there are some dads that really are very dedicated, and they show up in the NICU and stay as long, if not longer, than our moms sometimes. And I think that, they're not always as talkative. They're not always as willing to go and have conversations about, emotional needs or anything like that. But I think if we pay them attention, their attachment and their connection to their NICU baby is just as important as connections with moms. So.
And I think also kind of going with where they are, which is how's mom doing, right? So oftentimes talking about how mom is doing can be the pathway to how he's doing. So, kind of keeping that in mind. Okay, so finally taking baby home. So infant mental health, we have the first bullet point, which is we talk about the ideal baby versus the real baby versus the feared baby. So when a mom's pregnant or parents, right, mom and dad, they kind of idealize, they fantasize about this perfect baby that they're going to welcome into the world, and then over time they get a little bit more realistic. And then there's also the fear that happens. What if this baby is born? What if I give birth to this? And what if this happens to my baby? And how am I going to deal with it? So in the NICU, we often say the parents go from the ideal baby in their mind to the feared baby. Now what do I do? And when a baby goes home with all of these, as you can see in the picture, all of these medical equipment, which happens more often than we realize, I think, from the NICU. What does life look like for me with my feared baby? And have I grieved that? Who is helping me through this grief process so that eventually I may be able to accept and continue my dyadic bonding journey? And even when taking baby home means the baby comes home healthy, without any medical equipment, still for the mom or the dad, the baby may be seen still as a vulnerable baby, because my first experience with this baby was, if you recall that picture with the father kissing the baby you couldn't even see the baby. The head was all messed with the breathing apparatus and tubes and PICC lines everywhere. So that's the template that's been set. So for this parent, the baby is healthy and the medical staff can tell them all they want that your baby is healthy. For that parent, this baby is still kind of vulnerable. So I have to make sure that my baby will never get, quote unquote, never get sick again, never come back to this hospital, never have another code, never need another, respiratory help or something. So we kind of have to be aware of this and be able to go into with the parents into their narrative and help them kind of tell their story. And Sharon will take over from here.
Okay, this is probably a good point. I wonder how everybody's doing, but also, Charlene, how long more should we go before we have time for questions? Another 10 minutes maybe?
I think if we take another 10 to 12 minutes, that'll take us to about 3:15, and then I'll give us the 15 minutes for open forum questions and discussion.
Okay, wonderful. Thank you. So my part that I'm going to be focusing on will really be looking at interventions. But I wanted to present the idea of levels of care. This levels of care idea was presented in the pediatric psychosocial preventative health model of care, where you have the idea of universal care, where every care is provided to every family, every parent that comes into the NICU. All parents are given, parent-to-parent support if they're able to. They're given, family-centered, what we call family-centered developmental care. Hopefully they're all getting it at the bedside with their nurses. They're learning to kind of care for their baby, right? So that's a universal care. It's a more general, everybody kind of gets touched. The second level is targeted care. And these are where families are at risk for emotional distress. These are typically parents that Esther and I will get called on because other medical team members have noticed parents are in distress, or they need more support, or they're crying all the time. And this is where these parents get specific care from professionals. And NICU staff also kind of provide some of this targeted care and support. And then the third level, which is the slides, a smaller group of parents needing clinical care. This is just emotional care for NICU parents with acute or diagnosable conditions by mental health professionals. And these are parents that often get referrals for external mental health support services, and on the floor, Esther and I often kind of are on the unit providing them with support if they need it on the floor. So just holding these three levels of care, of course, we would love to be able to provide universal care and screening for all parents and families. But really, I think a lot of the work we do in the NICU has to do with targeted care and clinical care. So wanted you to just kind of keep in mind, if we could go to the next slide, Esther, to the pictures of kind of interventions in the NICU. If you look at the slide, I put a ton of pictures on there, but really if you want to hold how we look at the interventions in the NICU itself, we really want to do everything that we can to help the baby grow, to help the baby thrive, to help the baby overcome any kind of medical challenges that they might have. And then outside of that, we want to make sure that the parent and the child have a good connection, that they have a good growing, secure attachment. And then I put a little picture on there of the medical team, because really the interventions in the NICU we cannot do without including kind of the medical team members in caring for the baby and their family. So it's really kind of interventions targeted at multiple levels, whether it's specifically for the baby and supporting the baby, reading the baby cues, or being able to kind of make sure that the attachment is going on the right track, like Esther was talking about, which really kind of is super important for kind of helping the baby's brain grow as well. So the next slide, Esther, thank you for forwarding the slide. From the treatment reviews, just wanted to highlight some of their recommendations for interventions. I think we talked a lot about a lot of these parents get thrown a lot of information, a lot of medical information. So it's really, really important that these parents also get information about premature infant characteristics, and for them to become involved really early on in their infant care. So anything that, paraprofessionals can do to help support these parents gather that information, be open to getting this information or accessing this information is really going to be a good intervention and help. The other piece is that intervention should begin early as possible. I think in the work that Esther and I do, we joke, but we also kind of have seriously planned to say, hey, how can we get these parents earlier before they even come to the NICU to prepare them for what to expect and to help already set a pattern of positive parent-infant interaction. Also, I think there should be a push for more general screening for anxiety and depression for all parents. And I think what's really crucial in point D is to check what parents believe about what's going on, what does it mean to have a baby in the NICU. All the points that we talked about previously really should be checked out and woven into kind of the treatment that they interventions that they're getting. The next slide, Esther, if you would. Other suggestions from literature is that the intervention should have some kind of theory behind it, whether it's developmental, parent adjustment, a trauma model. Most of the interventions in the NICU are usually based on some kind of theory that drives the intervention model. We should also be looking at parent stress. We talked about parent depression and anxiety. A lot of the interventions in the NICU, and I'll break them down in a little bit, are very education-based. They incorporate a lot of education about infant cues, about being sensitive to the infant cues, and being aware if their baby starts to show any infant cues and how to kind of be more responsive. Of course, cost effectiveness is huge. And being able to, I think, point F, being able to have different levels of intensity of services is extremely important. I think at this point, we tend to be relegated to the more intense families that need more clinical care. But I think that it would be nice to be able to have groups, which we hope to roll out more, to be able to have maybe a lower intensity level intervention for these families to support them. So let's go to, I hope if there are any questions, please feel free to ask later. I'm going to dive more deeply into the specific interventions that are listed in literature. A big one is journaling. You'd be surprised to kind of find out how effective journaling is in decreasing stress in the NICU for parents. About journaling for 10 to 15 minutes. Traumatic events. And really the journaling helps the parents to kind of be in a little bit more of a reflective stance, to be open to make sense of kind of all that they've gone through. They encourage that parents maintain this journaling momentum during times of stress to cope. And really it does help them to kind of have a coherent narrative of what they've gone through, which will definitely help in translating into being able to attach and not have the challenges of unresolved trauma impact them. The other piece that's huge is parent support. The pieces of parent support, like I put there, is typically pretty individual. Individualized emotional support, psychiatric treatment. I think what I was really amazed by was the effectiveness of having a NICU parent graduate kind of be a peer support for these parents. That's really been shown to have a really, really good effect. Of course, all the other kind of evidence-based treatments have also been shown to be effective, like CBT and interpersonal psychotherapy. The third big intervention category is parent education, as I alluded to. A lot of interventions based on how to care for the infant, infant massage, how to recognize infant cues, and then preemie development, kind of understanding the developmental progression of preemie babies. I believe the next slide is how to support parent-infant interactions, and family-based interventions are kind of similar. Both are focused on supporting parent-infant interactions. In fact, the infant mental health piece, which Esther kind of talked about, and I don't know if you want jump in anytime too, Esther, when you want to. It really is helping the parent to have a more reflective stance, to be able to kind of see kind of what their process is and how that impacts, you know, their connection with their baby and what they're seeing with their baby. That's some of the infant mental health piece. The family-based interventions was interesting. The study was done where is it enough to just kind of give parents educational material or let them view, you know, a video about infant cues, and will that help them kind of connect more or help with the stress? Or would a more interactive kind of intervention be helpful, like actually showing the parent how to recognize infant cues, you know, showing the parent what their infant's reflexes are and their motor skills abilities. In fact, it showed that if you do either one, whether you actually kind of do it in person with them or give them educational material, it really enhanced moms' knowledge. In this case, they worked with moms, and moms' sensitivity and contingency or responsiveness to their infants, and really helped to lower stress. Okay, so those were all family-based kind of interventions. The therapeutic child development support intervention was more family-centered care, kangaroo care, which is skin-to-skin care, and NICAP, which we will kind of talk a little bit more in the next slide, which, and again, jump in, Esther, regarding NICAP.
Sure. Yep. So NICAP was developed by Heidi Owls at Boston Children's, together also with Dr. Brazelton. And it's really, if you remember, you know, sort of the parents' need to have accurate information and their need for all of the professionals in the NICU to work together and provide support and help from the family's perspective. This is what NICAP's sort of core goal is. So they're bringing in together the staff as well as the parents and the infants in one sort of cohesive experience. So reflective work, reflective facilitation for the bedside nurse is essential. The parents are able to also have some reflective moments where they get to kind of think through and develop more their narrative and their ideas or thoughts about their baby, their NICU experience. So it's a much more kind of well-rounded mental health, I guess, needs are more kind of in the forefront, not only for professionals, but also for families and for babies. So this is a very, it takes a lot of hours to get trained in NICAP, which is one of the barriers for a NICU becoming NICAP certified. But once they are, then it does kind of try to meet both the family's needs as well as the staff needs.
A very comprehensive program, right, Esther? A lot of work, but yes, very comprehensive.
A lot of work. Mm-hmm.
So post-NICU, so those were kind of interventions in the NICU, very varied, a lot of education-based, and we're really, me and Esther are really trying to grow kind of the relational, infant mental health, relational support interventions that can be done in the NICU itself. Post-NICU, in the literature, some interventions began prior to discharge. So this would be more kind of the education-based interventions again, just prepping and making sure that parents are empowered and feel able to care for the infant going home, whether it's learning about, the oxygen or learning about feeds or learning about how to use a G-tube. A lot of that are kind of interventions prior to discharge. And other things that might be going along with the medical condition of their child. Most of the post-NICU interventions after discharge tended to focus on home visitation. And so, yay for home visitation. A lot of it was very varied in terms of the length of home visitation. Some of them started from, 2 weeks to 3 years, to 3 years old, when the kids were 3 years old. And the home visitors were varied as well. The home visitors consisted some of PTs, psychologists, home visitors, and a lot of them also included kind of monthly parent group meetings, and educational and behavioral interventions were also huge. There was one home visitation program that really kind of helped parents to play with their infants, to recognize when their babies were dysregulated, and how to kind of help their babies kind of calm down using kind of body regulation kind of interventions. That was the home visitation with the PT and the psychologist. The other intervention were mother-infant groups. These were 1.5 hour mother-infant groups that met 2 times a month for the first year until the infants were 12 months corrected age. And in these groups, the mothers were encouraged to observe their infants and also to kind of verbalize their grief, their anxiety, their guilt, and to promote kind of social cognitive skills in their infants. And the results showed from that group that there were higher kind of personal social sub-skill scores, and that the babies had better hand-eye coordination. So again, a lot of kind of hit and misses in terms of the outcomes, in terms of we want to kind of get the attachment going and the emotion regulation, but the developmental outcomes are also showing that it's got a positive impact. So those were some of the posts. A lot of work needs to be done. The literature is pretty scarce in terms of effective post-NICU interventions, and so we really encourage people to try to support these families in a very, very vulnerable stage when they are home, with increased stresses with being a new parent at home, but also having to deal with sometimes babies that continue to have medical and developmental issues. Really need to start to get more research and understanding about what will be effective for these parents at home. So I think that kind of wraps up our presentation. I think we're going to open the time up for some questions at this point. So Charlene, it's time to you for questions. Are you reading the questions?
Yeah.
Or should we? Okay.
Absolutely. First and foremost, I want to thank both of you for a wonderful presentation. I think this has really spoken to everyone on the call, both whether they're in the hospital or in the home. I have one specific question to add, and then that came in through the chat directly to us, and then I can open it up to the larger group if that's okay.
Awesome.
Sure.
The question was, what are 2 specific things a home visitor should be aware of or can do in the home once the baby has come home to support the family and siblings?
The thought that I have immediately is how are mom and dad or the caregivers doing? So, in the NICU, they sort of, depending on how long they've been in the NICU, they sort of come to some sort of routine. And part of that routine is, unfortunately, their self-care goes out the window. So they're not sleeping well. They're not eating well. They're not aware of some of the stresses, tensions that they carry day to day in their bodies and their minds. So someone to check in, not only how you're doing, but specific questions about sleep, nutrition, sort of, how do you take care of your body? How do you hold your tension in your body? And are you kind of letting that go? And then the second thing is kind of, again, as we were talking about, some of the parents' thoughts about themselves as a parent and their baby, and how is this journey going. I think those two are sort of the big categories that I think of right away. Sharon, do you have anything?
Yeah, I think the other piece, so I definitely agree with you. I think stress, self-care is a huge issue, especially when they go home, and the stress kind of amps up, especially if they have, you know, other kids and having to deal with a baby that might still need a lot of care. The other piece was trauma. I think that apart from stress, I think I do feel like it's going to be huge. They parents in the NICU are so such a high level of stress. They really are living moment to moment. That I think that when they get home, it'll be really good to check if any of the trauma has surfaced. If they've processed, how have they processed? Has it come up? And again, I think what Esther talked about, you know, checking in on their sleep and their eating is a good avenue to start also wondering about the effects and the impact of being in the NICU on them, especially if there's unresolved kind of trauma from the birth and being in the NICU space where they are observing and taking in a lot of sensory information as well. So that would be my
Thank you, Sharon. I had one other thought come to me, which is, are the parents aware of who to go to in case of, and then you can list sort of different types of questions or concerns. So of course, foremost in their mind is what if something happens to my baby's health? So are they, because you know that sort of discharge process for the parents can be very overwhelming, especially if a baby is coming home with medical equipment. They tend to have tons of follow-up appointments that's supposed to be given to them printed out, but even going through that printed out discharge plan can be overwhelming. So if someone, if that's in your scope of work, that'd be great, to sort of, you know, go through the discharge paperwork with them and just to sort of double check their understanding, but mostly to figure out, do these parents know where to turn if there's a crisis not only in health, but their emotional well-being too.
Thank you for the response to that question. I do have one more question, but I would like to open it up to the larger group first. Does anybody have any questions? Any thoughts or comments?
Excuse me, I have a question.
I heard about 3 people.
Okay.
Whoever's name starts with closest to A first, go ahead.
For Fatima. I'll go. So my question
Let's go with Fatima first.
Okay. My question is how to balance the enrollment numbers with quote unquote advocating for families as an HL. And so how much do other HLs go into the NICU and talk to the medical staff? Or do they just go based on what the parents are telling them about how the baby is doing? And if so, is talking to the medical staff more of the home visiting role, like the RNs and the PC, or is it an HL component as well?
So this is Charlene. I'd like to address that question, and then Esther and Sharon, if you have additional feedback, please jump in. I think one of the critical things as an HL is being able to collect information or talk to other staff while the client is in the hospital. And since for the most part, we do know that 70-some% of our clients, their first entry into their program is through the hospital, the HL is really an important part of that process of collecting information. Depending on your capacity, I think this is a further conversation with your manager and your clinical supervisor. I would suggest being able to go and talk to NICU staff and determine, hey, you know, is there something else you can tell me for this family who is interested, or I am going to approach about getting them involved into our home visiting program, especially if they're going into the long-term home visiting program. I think spending a little bit of extra time, especially for these families that are already going through so much, is really important. And any information that we can get to best support them is the best case scenario. So I would almost invite you to not think about numbers for a few minutes, because you may not have NICU clients all the time, but they're starting to come up more and more. But it's definitely not the majority of your caseload. But I would definitely invite you to put the numbers aside for a little bit and just think about the clients individually and figure out what best would fit their needs and how we can help them.
Thank you.
Hi, this is Deborah. I'm a home visitor, and I can have up to 4 preemies on my caseload, and I've had 2 sets of twins.
Wow.
I do not have any way of knowing whether the client has received a regional center referral. And I wondered what criteria you're using when you discharge, what ones receive referrals and what ones do not.
That's a very good question. I used to know the answer to that. Forgive me. I think it's by gestational age. So if they're under a certain number of gestation weeks, then they automatically get, at least in our hospital, and we have a regional center liaison that comes from regional center to our hospital, and they sit in on our discharge rounds to kind of be prepared for families that are going home, and then they know to follow up with them. I would think that if you felt any need for a regional center assessment or referral, that I hope that you have support on your team to talk through that and then reach out to at least consult with a regional center.
I do that, but sometimes I find the mother has already been connected because she's filled out paperwork at the hospital, and then she's filled out duplicate paperwork because I have no way of knowing. Yeah.
Oh, got it. Okay. So what I would... Go ahead.
Sorry, I'm wondering if it'll be reflected on the discharge paperwork in terms of referrals and who they've been referred to. So I hear that, filling out forms, but yeah.
So I need to look at that. Sometimes it's not indicated on that either, but at least that's some place to investigate first.
You could, and if you're able to have contact with the hospital case manager for the NICU,
that's a good idea.
Some hospitals have just one case manager. Others, it's the social worker. Other hospitals, they have multiple depending on, parents' geographical area, etc. So I would just call them and see what happened.
Okay, thank you.
You're welcome.
Other questions? I've got a question.
I was wondering.
Go ahead.
Sorry about that. I actually was wondering if, Esther, if you can repeat the second thing that you stated about what are the most important things to do as a home visitor when trying to support your clients. You said check in with parents about sleep, nutrition, stressors, and are parents aware of who to go to with questions or concerns? And you said the second thing. If you can repeat that one more time.
Yes. Yeah. So this is sort of a general overall, and we can have a webinar just on this topic, but it's really about helping the parents, begin their narrative about what are they telling themselves about who they are as a mom or dad or grandma. What are they telling themselves in their head about their baby? So now they've come home from this NICU experience, whether they've stayed a few days to, several months, what's going through their mind that's definitely impacting their mental health and the baby's mental health and bonding. So you want to get curious about what's the message that they're sending themselves. And because this is all sort of quote unquote food that is being fed into this relationship, the mother-child relationship, father-child relationship. And so you want to sort of help them process and further themselves along in this journey. And this is the whole kind of dyadic support that we do. So the more people that will ask them specific questions about, you know, how has this NICU experience been? You know, what do you think about when you see your baby? You know, any questions like that to help kind of further that development is helpful. And I know you'll probably have more questions after this, but I hope that explains a little bit.
Yes, it did. Thank you very much.
You're welcome.
We have a couple of questions in the chat box. The first one is, during home visits, how do we talk to parents about child development when their baby is not developing at a typical age?
Sharon, you want to take that one?
I think it depends on their expectations. That's what I'm thinking as I hear this question. You know, kind of, are they aware of kind of expectations of development for a premature baby, or is it accepting that their babies are, you know, have some kind of delay? So I think if it's the latter, where they are faced with having to accept that their baby has some kind of delay, then that's a whole discussion about accepting kind of the real baby, like as we were talking about, kind of who's the baby that they have now in their home, and are they able to do that, and going through, I think, the grieving process with that and being gentle with them. So I hope that answers that.
Also, my other thought is I'm sorry, just to add, at what point would you refer out to a parent-infant dyadic therapy if that's something that could be supportive in this process?
What we also wanted is there any materials that talks more about premature development? Many times we're just waiting to see if the baby is going to catch up to their gestational age at some point. So we don't know if there's any delays yet, but how do we talk to the parents? Is there any materials that we can give them of what to expect, what to look for?
Yeah, I think there's, you know, definitely you can start with the 0 to 3 website, and that's very parent-friendly as well as professional-friendly. There's lots of information there on brain development, on, you know, all kinds of social-emotional development, as well as parent-child interactions and play that support that kind of development as well. So I would start with that. And I think, you know, you're speaking with your supervisors and managers for trainings on typical, atypical developments and what to look for. The website is 023.org.
May I comment?
Sure.
As a home visitor, we use Ages and Stages assessment tests, ASQ-3s and ASQ-SEs, which are social emotional development. So generally, when you put in how many weeks premature your baby is at the ASQ site, it will tell you when to start your assessments. So they may be delayed by 2 months. So you would be 2 months behind at each developmental benchmark. So you would know to do, you know, more slowly the developmental exercises, and you would delay your testing to meet what the program tells you to meet. And you would do a referral to, we do a referral to Regional Center for In-Home Services, someone who comes out and does an assessment.
Right, yes, thank you for that. That's a very good tool to use, the Ages and Stages questionnaire and their website, and they have a summary sheet at the end that actually guides you and points you towards a likely referral or not. But another word of caution is that Ages and Stages is a screener. It's not a full developmental assessment, so we do have to keep that in mind.
That's why you have to refer to Regional Center.
Right, and that all babies sort of develop in their own pathway, time-wise.
Yeah, and I think just to add, if you don't have the ASQ as a tool or any kind of screener, at the end of the day, I always really concerned about the development of their child. That's an enough indicator to refer them somewhere to get a developmental assessment to rule out.
That's right.
Any kind of delays. Okay.
We have two more questions. The first one was, what are specific ways to engage disengaged parents who is clearly taking care of their child, but there's minimal effort or response to bonding and attachment?
Mm-hmm. That's a good question. And there's multiple reasons, right? And sometimes as professionals, sometimes that's hard to see, and our own kind of feelings and thoughts and judgments and assumptions also get in the way, which is why we all need reflective facilitation. But I think that would be a dyad that would really be able to use the parent-infant mental health support. So I would refer them, to parent-infant dyadic work. For your interactions with that mom, I would really just focus on how she's doing. And I don't know if when I sit with a dyad like that, my sort of protective urge goes to the baby. And I worry about the baby's development and what kind of stimulation could this baby be getting from this caregiver. Is she neglecting the baby emotionally? Those concerns come up. But I know that that's the first sort of instinct of mine that I have to kind of sort of become aware of, and then I have to go to where this mom or dad is. And if this mom is disconnected and only doing functional caretaking, not really emotionally bonding, what is it that this mom needs? And I have to get in touch with that in order to then support the baby. So, kind of keeping in mind the reflective goal, which is that the professionals have to support the parents so that the parents can support the infants. And if that kind of order gets toppled, then kind of we create more chaos. So just keeping that in mind and then looking for some referrals for this dyad would be a good idea, I think.
Thank you so much. The last question in the chat box was, would you be able to create a welcome baby protocol for NICU babies? For example, is there a cutoff of how early we can approach a NICU mom for welcome baby based upon how early the gestational age is? Are there other welcome baby sites able to visit, other NICU welcome baby sites to visit infant in the NICU if they are transfers for best start and non-best start? If infant's diagnosis too severe, are they still able to benefit from welcome baby services? Angie, I did get your question. I think you're bringing up a really good point in terms of a protocol, and I'd like to hold off on answering that question because I have some pending questions for Esther and Sharon that might inform this decision and whether or not we will move forward with an actual protocol on it. All right, I apologize. I know we are 10 minutes over, but it's been a really good discussion. Again, I really want to thank Sharon and Esther for their conversation, their wisdom today. Thank you so much for bringing this important topic to us. I want to thank everyone for being engaged and participating in our conversation. We will send out a link of the recording along with the PowerPoint presentation after this call is done. So everyone, thank you so much. Really appreciate it. Esther and Sharon, again, thank you so much to you both. And I hope everyone has a wonderful Thanksgiving. Thank you.
All right.
You too.
Thank you. You too.
Everyone.